So now comes the retina. So we were because we saw the tapetum, we thought I will tell about tapetum little, because that is how when you to your eyes it will appear, but the layer that is present above the tapetum is the retina. Retina, the tapetum of the choroid, and then the sclera. Of course, the retina is composed of different layers like this, and the one thing you should understand here is that you can actually divide the retina into clinically into two. That is, the first retinal pigment epithelium outside and the inner neurosensory retina. So whenever there is a retinal detachment, the detachment happens actually here between the pigment epithelium and the neurosensory retina. So where the here can come to this picture. This is the retina, and this is the retinal pigment epithelium, and this is the choriocapillaries. Another interesting factor is you will find pigments in the all these are pigments in the retinal pigment epithelium. You also have pigments in the choroid capillaries. So that pigments, the main purpose is to absorb light, so that you will get a focused picture on the retina. Then this is the choroid with the vessels and again the pigments, and here you have the tapetum. So the detachment happens between the retinal pigment epithelium and the neurosensory retina. This is a histological structure, which is a very common picture you would have studied earlier also. And here again, this is the pigment epithelium, and this is the neurosensory retina, the 9 layers. And the detachment happens here. This is the area. This is, you can see a detached retina here onto the towards the vitreous. So what happens, you will see when you examine the animal with the help of an ophthalmoscope, the retina will be placed more anteriorly towards the vitreous. You can also again see in this video. This is mainly to tell you the anatomical relationship between the pars ciliaris retina, the vitreous, and the. You'll be able to see the retina also in this. So this is the pars ciliaris retina. You can see the pigmented part here, and once you lift this is the vitreous, and you are trying to lift this, and you can turn it around also. Yes, now you can see the structure. This is a, can you see one structure here? That is the retina. This is the translucent area you can see here. That is the retina. Now coming to the vasculatures. So the main supply is mainly by the common carotid artery. From the common carotid artery, it continues as the external carotid artery, which again continues as the maxillary artery. And from the maxillary artery, you get the external ophthalmic artery. So the major supply of the eyeball is from the external ophthalmic artery. And also you have another arterial supply towards the iris, which forms the major arterial circle of the iris. And that is why iris is a highly vascular structure, and it is actually an enemy for the surgeon, I will say. Whenever you do surgery, you should be very careful not to handle or touch the iris. Inflamed iris always will bleed also. Now comes the optic nerve, which is the combined portions of the, we said about the neurosensory retina. So combined axons of the ganglion cells, all these will form the optic nerve, and it is again surrounded by the meninges. So, and between in the meninges also, it's a continuation towards the forebrain, and you will also find it is a continuation of the dura mater. So that is why eyeball is a direct extension of the forebrain. And this optic nerve, which comes out from both the eyes, will cross over. That is called the optic chiasma, and this optic chiasma is present very adjacent to the pituitary gland. That is also very important anatomical relationship. So we said that axons from the ganglion cells escape outside, and it forms a optic nerve. During this process, what happens? It has to definitely pierce the sclera. So that area is called lamina cribrosa. Okay, this is a very highly dynamic dynamic and compliant structure. So that is why during every movement of the eyeball, you will find that the optic nerve is not compressed. Only when there is a pathology, you will find some compression of the optic nerve. In an anatomical, or physiological movement, you will not find any compression of the optic nerve. So that is why one of the famous glaucomologists said that, see, many axons are actually passing through this area, but it is not causing any leak at that site, in the lamina cribrosa site, throughout the age of the 15 years of the dog's life. Okay, so that is actually a wonder, that because the lamina cribrosa is a dynamic and compliant structure. That is why you don't find um, any like degenerative changes, I should put it in that way, because that happens with the age. So you will not find here on the optic nerve or at the optic um, area where lamina cribrosa um, happens on the sclera. Now this is the fundus anatomy, ocular fundus anatomy, where this is the roughly triangular area called the tapetum, and you have the optic disc here, and this is the non-tapetal area. The rest is the non-tapetal area. And I said in case of animals, you have area centralis, not macula. It is area centralis. And you have retinal arterioles, and then arterioles are very thin when compared to retinal veins. And this is the medial side, and this is the lateral side. So this is of a left eye. You will also find a central depression on the optic disc, that is called the optic cup. Normally, there is a relationship between the optic cup and the optic disc diameter, and this is given importance when you do any um, fundus study, mainly for glaucoma. So actually what happens when there is pressure on the posterior side, the optic disc will be pushed backwards, and that procedure, that phenomenon is called cupping of the optic disc. So that is why you should know what is an optic disc and what is an optic cup in the center. And this is the optic, this is a tapetal area. One more point I wanted to tell here. Yes, so this whole area, you can see in the fundus anatomy or in the fundus picture, you can see the optic disc, you can see the tapetum, you can also see the non-tapetal area. So this is the picture you will get with the help of an indirect ophthalmoscope. Whereas when you use a direct ophthalmoscope, you will be at one point of time in the visual field, you will see only this area alone, because the magnification of the direct ophthalmoscope is more when compared to the magnification of the indirect ophthalmoscope. Just to give you some examples of different fundus, because I said in the first slide itself, variations in the normalcy. So that is why you should have a good patience to study the anatomical differences, normal anatomical differences. So this is the variation you will find in case of, this is a normal fundus in a Labrador Retriever, a typical, we can say a typical canine fundus. This is how we explain. So these are this is a, this you appears thick when compared to this. So this is the retinal vein, and this is the retinal artery, and you have the non-tapetal area. This is the non-tapetal area, and this is a tapetal area. And invariably, you will find the optic disc at the junction between the tapetal and the non-tapetal area. Very rarely you will find the presence of the optic disc in the tapetal area itself. And within the disc also, you will find a rough C-shaped curve of the retinal veins and arteries. And this is the, in a fundus picture in case of a spaniel, the color of the tapetum differs. So I said here it is orange, and this difference in the color of the tapetum again correlates to the coat color. All these pictures were taken from the Veterinarian Key site. This is a German short-haired pointer where you can see some halo-like thing around the optic disc. So this is a normal thing. It is not a pathology. If this happens in other breeds, it is a pathology. Okay. So that is called excess myelination. So excess myelination of the optic disc happens in optic neuritis. Sometimes if there is attenuation, you will not find. Otherwise, you will find optic disc myelination. So this is called pseudopapilledema. Otherwise, the condition is called papilledema. In this breed, it is pseudopapilledema because it is a normal variation. This is again a normal variation, again in a spaniel breed, where you can see little part of black color around the disc. So that is called pigmentations on the choroid, the structure behind. So you can see thinning. That is why you can see little of the choroid here, and these structures are called conus. Again, this is not a pathology. Coming to the cat fundus, it's very highly reflective, and you should always be very careful whenever you use a high intensity light towards the, do not shine into the cat's eye. So control the rheostat in the machine and try to reduce the intensity of the light when you use such equipment on the cat's eye, because it is a highly reflective tapetum. And the cats also, they have a differences are the third eyelid, they have a voluntary control over the third eyelid, and they have a vertical pupil. So all this makes a, and they also have a deep anterior chamber. So all this makes cat's eye a more nocturnal, because their vision is more good in the nocturnal night time. Whereas in case of dogs, they are not either nocturnal or diurnal. Their vision is good during dawn and dusk time. That is why they are called eurythmic. Now this is a schematic diagram or various spaces within the chamber. So the black structure, here it is called the anterior chamber, and anterior chamber is between the iris and the cornea, and it continues behind the iris, that is called the posterior chamber, which surrounds the lens. And behind the lens also there is a small space called the Burger's space. This is a Burger's space. Then you have the Petit's canal here. The Burger space continues towards the zonule. There also you will find a small canal. And this is the actual vascular supply during the embryonal life. That is called the hyaloid artery, runs through the Crockett's canal. And these are all the fibrous bands you find inside the vitreous. And this 13 is important, that is the anterior hyaloid membrane. Anterior hyaloid membrane. So these are the two structures you should be very careful when you do cataract surgery: the posterior capsule of the lens and the anterior hyaloid membrane. So if there is a rupture, what happens during surgery? The vitreous will propose herniate into the anterior chamber. Second, vascular supply. Now coming to the various the physiology, that is aqueous barriers. The blood aqueous barrier is seen at two regions. One is the barriers at the blood aqueous, that is between the ciliary vessels and the aqueous humor, and another blood retinal barrier, that is actually a in the true sense, it is a barrier because it has got both endothelial and epithelial portions, which is seen between the choroid and the retina. So these barriers are important in the sense it is mainly to protect the eye from the surrounding systemic circulation, any toxins or any they don't find any entry into the eye. So that is basically a protective mechanism. That is why we also say that eye is an immunologically privileged site. So what happens when there is inflammation? There will be breakdown of all these. In fact, because of the breakdown of all these barriers, there will be penetration of the drug into the eye also. So that is taken as an advantage. So we have seen up to the various phases and also the production of the various the ocular barriers. Now we will see the production of the aqueous humor and also the other visual pathway. So we were talking about the optic nerve, which are combinations of the axons of the ganglia, and these are the visual field. So this is the eye. If you have a structure here, the light emanating from here, that is from the lateral side, enters into the eye. This is the left eye and the other one is the right eye. And there will be bending of the rays when it actually traverses through the precorneal tear film, cornea, the lens, and it falls on the opposite side of the retina because of the bending. So also from the nasal side, this is the field and it falls on the other area. Okay. So what happens at the chiasm? This is the optic chiasm, this area. So the stimuli or the impulses which are taken from the peripheral, the lateral side, will cross over, and also from here it will cross over and it will come to the opposite side. So from the lateral aspect, whatever light rays or the images that enter into the eye will find a place finally on the right hemisphere, whereas from the left it will goes towards the right hemisphere. So this is mainly because of the chiasm, optic chiasm. So the optic chiasm is very important, this decussation. It is less in case of cats, it is 65%, and in dogs it is 75%. And also the optic chiasm is less whenever there is a more binocular vision. That is also another important thing you should know. In case of human beings, it is only 50%. Again, another picture which tells you about the visual field, the optic chiasm, and this is the optic tract, and it enters into the lateral geniculate body, and from there the optic radiations, and then into the occipital cortex. So now next is the nasolacrimal duct. So this is also another important physiology you should know. You have the upper punctum here, you have the lower punctum here, and then it gets drained through the nasolacrimal duct. So the blink reflex actually helps in the production of a little vacuum on these areas, and that is why the fluid gets drained into the canaliculi and it gets drained through the nasolacrimal duct. Any obstruction in the nasolacrimal duct, you will find epiphora. The tear, which because it is a colorless liquid, you will not be able to appreciate the tear well. But when you put a fluorescent dye in the eye, you will be able to appreciate this tear well very clearly. Again, the precorneal tear film, we have studied that it has three layers. They are the mucus layer, the thick aqueous layer, and then the thin oily layer outside. So that is one fluid. The another fluid or the humor which you find inside is the aqueous humor, which is produced by the ciliary body and it gets drained. So the production and the drainage, it is very important to maintain a normal intraocular pressure. So the formation and the drainage should be kept at an equilibrium. And there are different ways to lower the production of the aqueous humor. You can reduce the production of the aqueous humor from the ciliary body with the help of different drugs, as well as you can also increase the filtration through the trabecular meshwork. So there are different surgeries to increase the drainage also of the aqueous humor. Now, dimensions I said are very important. That is, the corneal thickness is very important, which is measured with the help of a pachymetry. Then this is the anterior chamber. Then this is the lens thickness. So when you do an ultrasound, for example, here you can see. So this is the cornea. This is the anterior chamber. Then this is the lens thickness, and this is the vitreous. So you will be able to say whether there is any structural abnormality on the posterior sclera. Okay, this is called scleroretinal rim in the ultrasound image, scleroretinal rim. So if there is any structural damage is there, for example, a detached choroid or a detached retina, so all this you will be able to appreciate prior to surgery. And also the thickness of the lens. If the lens is very thick, more thick, you can predict that you might require more time to finish the surgery. So and also that is for the surgeon's advantage, but these dimensions are also important to predict the intraocular lens power in animals. You can, though the dogs are not going to read, at least you can customize the intraocular lens power that is required for each patient. So you have different formulas for which you need the measurements of the depth of the anterior chamber, the thickness of the lens, then the total distance from the cornea up to the posterior pole, that is called the axial length of the eye. So all these measurements are important to arrive at the intraocular lens power that is required for animals in the visual rehabilitation methods. Field of vision is also important. In case of dogs, the binocular vision is only 60%, whereas in case of horse, it is 65%, but the uniocular vision is more, 146 degree is there, whereas in case of cat, because their frontally placed eyes, they have a 140-degree binocular vision. Now comes the refraction. So you should know what is a normal refraction. That condition is called emmetropia. So in emmetropia, when the light falls on the cornea and there will be a bend, this is what I said, a bending will be there of the rays, and then it will be, because it is a biconvex lens, it will bend again and it forms a sharp image onto the retina. That is called emmetropia. If the image falls a little anteriorly, it is called myopia. This is myopia. This is also myopia, and this is hypermetropia. Okay, if the image falls behind the retina, it is called far-sightedness, near-sightedness, and this is the normal sight. So changes happens. For example, here you can see the retina. The light falls on the retina at a particular point. This is an emmetropic condition. This is again a emmetropic condition. See here, this is again emmetropic. Here also again emmetropic. But what is the changes you see here? The anterior chamber is very shallow. The anterior chamber is deep. This is a deep anterior chamber with a very big biconvex lens. This is in a case of a cat. This is a dog, whereas this is in case of a human being. So that tells you that the lens is very superficially placed. So for a surgeon, it is very easy to approach the lens, whereas for us it is very deep. Okay? Approach to the lens is deep, and also there are variations between the human eye and the canine and the feline eye. Normally we use a caprine eye or a pig eye as a model to study the structures within the eye, mainly the anatomy. This is another interesting thing which you should know. In case of this is vitreous elongation. See, when the vitreous is elongated like this, what happens? The focus will be more in front of the retina. That says that it is a myopic eye. So usually you will find this vitreous elongation as an inherited mechanism in case of Labradors. So that is why you find in Labradors, many Labradors will be highly myopic. Then myotic people. So that is very important. We were talking about something about meiosis, because this is a very common thing now they do in case of human beings, that is called pinhole pupilloplasty. So what happens, why you want to do reduce the size of the pupil to improve the image, to improve the clarity. So they say when you reduce the pupillary size, you will be able to see better. So this is in case of a human being. After this is a intraocular lens. So following after this is called a pseudophakic eye. So the particular person, he met with an accident, and because of the accident, the car accident. So the air balloon actually it resulted in a contusion wound on the eyeball, and that resulted in tear of the zonules as well as the iris around. So the surgical correction for this is reducing the pupillary opening and to improve the vision. So what happens when the pupil is wide open? Okay, when the pupil is wide open due to trauma like this, or it can also happen due to mydriasis. So we use tropicamide or atropine to affect pharmacological dilatation of the pupil. So during this time, what happens? There will be more spherical aberration of the dilated eye. In this, you can see the spherical aberration will be more. So because of the spherical aberration, you will not get a good vision. So the image will be blurred. So when you do a myotic pupil, when you reduce the size of the pupil, the spherical aberration can be avoided, and the blurred vision also can be reduced. So you will get a good clarity. So that is why after dilatation of the eye, what happens when you go to an ophthalmologist? After dilating the eye, necessarily they will ask you to put a sunglass, or they will ask you not to go out in the sunlight for some time, so that the effect of the pharmacological dilators will fade away. So here you can see a cat with a normal. So this is what I will say. They are already having a good vision because of a normal vertical slit in the pupil, almost affecting a pupilloplasty. Visible spectrum, color vision. This is again a debate that is going on in the animal side, but they say in canines they can see two shades. Uh, that is mainly they see the yellow as well as red, probably by yellow by dogs seen as in the range of 500 to 600 nanometer, and they also see blue violet range as blue. So they see only two shadow. Whereas in case of cats, they are replicate the human trichomosy, but the trichomosy means all the red three colors can be identified, but it will be very pale. It will appear to them as a very pale shadow. Mobility of the eye is again depends upon the ocular muscles, which we have discussed about the straight muscles and the retractor oculi muscles and its importance. And so such a mobility will not cause any defect on the optic nerve also, because there is a bend in the optic nerve also. Hence, the mobility will not cause any stress on the optic nerve. Now coming to the familiarity with some diagnostic equipments. So we have studied about these various anatomy. So we need, with our naked eye, examination is going to be very difficult. So that is why you need two basic things. One is the illumination and another is the magnification. To get magnification, you have different types of things like this. You can use a pentorch light. You can also use an optivisor like this, which provides good magnification. And or you can also use a binocular spectacle like this. So these are all called binocular loops. So that also you can use, and then you can it will also help. But only thing is the working field will be very less when you use a binocular loop like this. Then you have the basic instruments. They are the diagnostic equipments are the direct ophthalmoscope. So when you say direct ophthalmoscope, you are not going to put any um, condensing lens between the examiner's eye and the patient's eye. You are directly viewing the eye. That is why it is called a direct ophthalmoscope. The video is not playing. Okay. So this is a direct ophthalmoscope by Vishal. This you can see here. There is a dial here. So with the help of that, you will be able to change. And also here there is a, so now this is switched on. You are able to see the light coming out through the view hole. And this is the main switch. With the help of that, you can switch on the direct ophthalmoscope. And there are also filters like this. So with the help of that, you will be able to use the amber colored filter or green filter or blue filter, etc. You can also reduce the aperture size if you want to examine the lab animal or an adult animal or a cow. So accordingly, you can reduce the aperture. And here in this, actually, you have a rechargeable battery. That is very important. But this pocket-sized Welchalian direct ophthalmoscopes will have a battery. So these batteries, when you use, actually, they are all will be weak. That is why I don't prefer this. Always try to use a rechargeable battery. And in the direct ophthalmoscope, here you have a on the side. So there is a wheel. So with the help of that, you will be able to alter the diopter of the lens which you are going to use for viewing the various structures inside the eye. So you have red as well as blue. The red filters are mainly negative lenses, and the blue or the black are the positive lenses. Then you have the indirect ophthalmoscope. So the advantage of an indirect ophthalmoscope is it is again binocular. Direct ophthalmoscope is uniocular, whereas indirect ophthalmoscope is binocular. And another advantage is you can examine the animal from a distance. So according to your head size, you can actually adjust the size, and also you can alter the size of the IPD, that is interpupillar distance. You can switch on the rheostat, the main switch. Then you will see the light here coming up. And you can adjust the IPD here manually. So there is not a thing. So you can adjust manually. You can see. So these are the two oculus that you can adjust according to your. So all these things you should get familiarized before using it on a patient. You can examine your colleague's eye. That will always help to get familiarized with such equipments. Then you also have additional mechanisms here to change the openings, that is the slit or the color. All these things you will be able to adjust from the sides. Now we can also examine on the patient. So always try to just use a toy so that it will be easier for examination for a documentation. So you can actually keep an intraocular lens, a condensing lens you can take in your hand. So the condensing lens that you use in case of an indirect ophthalmoscopy is plus 20 diopters for the canine eye, and plus 5 diopters for the large animals, and plus 40 diopters in case of lab animals. So always I try to wet the eye with the help of a collyrium or some artificial tears, and you can switch on the machine. This is a handheld indirect ophthalmoscope. I like this ophthalmoscope very, it is like a toy because it is a very portable thing. You will be able to handle it very efficiently. So this is the condensing lens, which will have a convex and one area is plane. And on the plane area, you will have a white ring. So the white ring of the condensing lens should face the eye side. So this is indirect, means because any condensing lens is interposed between the patient's eye and the examiner's eye. So now you can see I am resting my middle finger on the periorbital area, and at the same time moving the condensing lens up and down to get some magnification of the structures which you are viewing through the with the help of a indirect ophthalmoscope. Now, another important equipment which is needed is the tonopen, that is intraocular pressure. So you have a button here, so you can press that and the cal will appear here. That is how you have to calibrate the tonopen bed. So the cal will come and you have to hold it in this position for a while, unless you can see here, then the up came, so you can revert it, and now it is reading good. So that means the calibration is good. If the calibration is not good, a sign bad will appear here. And the equipment, this tonopen bed is very useful in case of animals to measure the intraocular pressure. One advantage is you don't have to raise the head of the animal towards the roof. And another advantage is even if there is some corneal pathology on one area, you will be able to measure the intraocular pressure in the eye. So these equipments are very important initially, and you have additional equipments which we will see in the diagnostics, but these things are very important. And again, to tell you, to study the normal intraocular pressure or to view the structures what we have mentioned, all these equipments will help. So you can start practicing this, and I think we have covered all these areas, all these structures in the eye with the help of these slides. Yes. So the various resources that I used are the Essentials of Veterinary Ophthalmology, 4th edition by Gillette, Notes on Veterinary Ophthalmology by Sheila Cripson, Veterinary Ophthalmology by 2 volumes again by Kirk and Gillette, and Miller's Anatomy of the Dog, which is a Bible for the dog's anatomy. So all these resources, plus you can always use other plenty of resources that are available on the web. Thank you.